Good morning, ladies and gentlemen. Good morning, Mr. Chairman. I want to congratulate the organizing committee and thank them for inviting me to this lecture for the Pan-Arab Continence Society. I was asked to present the ureterovaginal fistula. Actually, it is an abnormal communication between the ureter and the vagina, and as you can see, it could be with complete section of the ureter or with partial. So many presentation can happen with this. It's a rare genitourinary fistula that usually developing secondary to iatrogenic etiologies. It is not common, it ranges between 0.5 to 2.5% of the cases, and can happen after a cesarean section, after hysterectomy, or excision of complicated or huge ovarian cysts. There is also a case report which is following spontaneous vaginal delivery after obstructed labor. We didn't see this, in Africa where we go frequently, but this has been reported. Ureterovaginal fistula leads to continuous leakage of urine through the vagina, usually after 1 to 4 weeks post-operatively, and with normal voiding and desire, because there's another kidney that is secreting urine, so the bladder fills normally and there is normal desire to void. Predisposed to urinary tract infection, pyelonephritis, renal scarring, and affection of renal function, and of course it affects the quality of life of the patient and with the impact on the psychological status. The vaginal examination can demonstrate a hard indurated area of fibrosis due to the fistula tract itself and secondary to the irritation from the leaking of urine out of the fistula. The diagnosis is not difficult, but for example, if you have leakage, you can use the double dye test or the vaginal ghost test, which can differentiate between vaginal and ureterovaginal fistulae. And of course, we can use IVP, intravenous pyelography, or CT scanning, retrograde pyelography, or antegrade nephrostogram or pyelography if the retrograde is not feasible. The double dye test is having pyridium to 100 milligrams 3 times per day, and you can inject methylene blue or indigocarmine into the bladder using a catheter. The pyridium will turn the urine orange in the kidneys, and the methylene blue or the indigocarmine will give a blue color in the bladder. And putting a tampon can turn blue if it is vesicovaginal fistula, or orange if it is ureterovaginal fistula, or both if you have both fistulae. The vaginal ghost test is inserting vaginal gauze and then injecting methylene blue in the bladder with a catheter. If it is stained gauze, though it is a vesicovaginal fistula, no staining, no fistula, wet but not stained, so this could be a ureterovaginal fistula. Intravenous pyelography can show you the part which is damaged of the ureter and whether it is partial or complete. Also, the CT scanning with delayed contrast films can show you again the site of the fistula or the site of the affection of the ureter or being obstructed or fibrosed. Retrograde pyelography is important. Sometimes you can pass through it and sometimes you cannot. Sometimes the dye will go up to the kidney and sometimes it will stop at the injury. That's why you can use an antegrade pyelography, and sometimes you can pass a guide wire or even a double J from in the antegrade direction, and sometimes it passes better than the retrograde. Looking at the management, our goals is to preserve the renal function, which is the most important, prevent or treat urinary sepsis, and cure the incontinence. So the options are observation to give time if it is already late for the cure, make an internal drainage via a ureteral stent or double J stent, or external drainage via a percutaneous nephrostomy, or going to the open surgical repair and nephrectomy if the kidney is really damaged. There is no clear consensus on the accurate timing of repair. Some group of surgeons will prefer early repair once the diagnosis of the fistula is noted, and some or other group will prefer the delayed repair after establishment of the fistulous tract and proper identification of the unhealthy segment, which I personally prefer. Looking at the conservative treatment, only a few reports showed that this happened, and in my practice, I didn't see that it resolved completely if it happened as a fistula. But the following factors should be present. If you don't have distal obstruction, no signs of infection, and with proper nutrition of these patients, and very small size fistula. For the drainage, as we mentioned, either we have put external drainage by PCN, and the advantage of this, it can be done under local anesthesia. There is accurate assessment of the fistula tract through an antegrade study and define the unhealthy segment which facilitate the further surgical repair. Or internal drainage with ureteric stent, which is really preferable if it passed. And the advantage is that has better patient satisfaction with earlier return to daily activities and until the definitive management is decided. And healing can occur also on the internal stenting. So sometimes with this prolonged stenting, the ureter can heal and regain the activity. What about the surgical repair? There are some principles that we need to take care of, and which govern the appropriate surgical repair. That all abnormal ureter should be sacrificed. We don't leave any unhealthy part of the ureter because this will end in definite fibrosis and stricture. Little attempt should be made to stay extraperitoneal. Some of these cases we have to go intraperitoneal, especially with recurrent cases or with fibrous, a lot of fibrosis. But then at the end, we have to extraperitonize the area of anastomosis. Continuity should be reestablished between the normal ureter and the bladder. I mean, what is left from the normal ureter and the bladder. We have to find a way. Adequate drainage must be provided. Do not over-dissect the ureteric cheese to preserve the blood supply. Ureteric mobilization has to be done properly to ensure tension-free anastomosis. You need to do a watertight closure over a ureteric stent. The end-to-end ureterostomy is the best option if you have enough length of the ureter from below and above. It could be achieved. Sometimes it may be accomplished, but only in the instance of limited inflammation and minimal ureteric loss. Ureteroneal cystostomy, of course, is the surgery of choice and the preferred repair. It bypasses the site of injury of the ureter, obviating the need for direct localization. And you can do whatever type of ureteroneal cystostomy you prefer, or you master lesion Guar, polytunnel better, or others. So this is up to you. But you need to have, a good length of the ureter. That's why sometimes you need to do a psoas hitch, which is used to in many cases combined with this ureteroneal cystostomy to ensure that the anastomosis is secured without much tension. It needs good dissection of the bladder with careful mobilization to place the sutures properly between the bladder wall and the psoas muscle tendon. The last action in this is the Boari flap with much loss of the ureter or with shorter ureters, and you need to design the bladder flap carefully and then to fashion it and to reach it to the ureter. Sometimes you can also combine with the psoas hitch. And it is always advisable to implant the ureter with a submucosal tunnel as much as you can to make trial not to have reflux and more UTIs. The precaution that should be taken before this surgery, what's the gynecological surgery, it can be avoided. We need to do proper imaging and planning, and maybe using ureteric stenting and proper surgical dissection and handling of the tissues to avoid ureteric injuries in these cases. Thank you for your attention.